Hi, Michael. Welcome to the Big Unlock podcast. I'm very
Afternoon.
excited. Yeah, thank you. Very excited to have you here. This is, season six. There are over 100 and I think 65 episodes at this point in time. So, the healthcare audience is super excited to listen to or I hope listen to our podcast. And I'm Rohit Mahajan. I'm the managing partner and CEO at Big Rio and Demo Consulting. And with that, I would like to request you to make your introduction, Michael.
Yeah. Yeah, I'm excited to be here too. Episode 100 plus. Wow. You've been going for a long time.
Since 2018.
Yeah, I'm Michael Marchant. I'm the director for digital applications at Sutter Health. Been here almost a year now doing their core interoperability, enterprise data integration for Sutter Health, as well as run their Community Connect program with about 250 practices. And have been doing interop for a long time. I participate on the Epic Care Governing Council. I'm on the Care Quality Advisor Council. I'm on the eHealth Exchange Board. So interoperability and health technology are core to what I do every day, making decisions and really planning for the future of how we get people the data they need to make the decisions around their healthcare each day. So excited to be here.
That's cool. So, Michael, would you like to share, please, with the audience about your journey in healthcare? What got you started? Which are some of the previous roles that you have played? What do you find interesting about it? And things like that.
Yeah, it's actually a very interesting and long story. I went to college back in Virginia at Old Dominion University. Was studying human resource management and kind of doing a couple different things. I ended up as an internal auditor, and my father actually worked for a small software company named CompuCare. And when I moved from Virginia to California, that office was looking for a software installer to do the patient financials of AP, GL, payroll personnel. And I had some technical background, but really nothing in core software implementation. But they were willing to train me, and I got on board. And one of the things about interoperability is that the first thing of interoperability is if you're an employee and you want to get paid, that company needs to send the information to the bank so you get your check. Well, I was doing the payroll install. So that was my first real foray into sending data from point A to point B with a real critical business purpose of making sure employees for an organization got paid with that CompuCare software. I moved from that into accounts payable and general ledger. Again, a lot of exchange and data in those frameworks, building print queues. And then CompuCare had a partnership with DataGate, which had an interface engine. And I started working in programming in that. And my kind of career in health IT took off from there. I moved after we had kids. Being in Southern California wasn't a good, a very
Yeah.
affordable place at the time. My wife, even though she has an advanced degree, really felt like having her stay home with the kids was the right move for us. So we moved to Sacramento, and I started with Sutter. Went through the Y2K program with Med Series 4 and went around to all the sites doing the integration for making sure all the interfaces were Y2K compliant. So going from 2-digit year to a 4-digit year and all the backwards compatibility there. And really worked my way up at Sutter. I went from an analyst and project manager to being the director over the team. Sutter Connect brought me over to run the Community Connect program. And at the time, it wasn't Community Connect. We called it Independent Practice Services. And
Right.
that was doing clinical integration for those small practices with the GE product. GE had recently bought IDX. So IDX and GE, and we deployed that, started the program here at Sutter and deployed that to about 50 or so practices, about 100 physicians before I left, and then moved on to working with the state contractor for the EHR incentive program. So ACS Xerox had partnered with the Department of Healthcare Services to deploy the enrollment portal for the state of California to allow physicians and hospitals to get access to those incentive funds to adopt technology. Ran around the state, built the portal, did the enrollment, did the training. And after that
Wow.
program, at the end of that stint there, we had
Hmm.
paid out about 500 million in incentive funds.
Great.
And so our job there was done, and moved on to working at UC Davis and was the director there of their interop and innovation team, and became really involved in industry. So that's where I got involved with care quality. I was on the HL7 interop committee, actually the blockchain task force. I still have a small slight. I think blockchain can do some things that we might need, but people are a little
Yeah.
uncomfortable with it. And was there for about 10 years, and then recently returned to Sutter, where I run those two teams. And For me, technology is kind of in the background and really serving a purpose, automating, making things easier, making things faster, getting the right information to the right people to make the best decisions about care are really what drive me each day to improve these processes and deliver for our internal and external customers, internal physicians, clinicians,
Yes.
and the patients. I mean, this creates better care, and that drives me every day. Really trying to emphasize that for our teams. You get stuck in the weeds of programming interface or writing
Right.
specifications, and you sometimes you can't see the forest for the trees, sort of thing. But I'm really trying
Sure.
to bring that up. So
That's awesome. Awesome. And Michael, could you talk to us very high level about Sutter as an organization in terms
yeah,
of,
yep,
patients that are being served and locations,
yeah.
hospitals and physicians and some size?
For sure. So Sutter Health is a large organization in Northern California. They call it the Sutter footprint, goes from about Sacramento or a little north and east of Sacramento down to now Santa Barbara. We actually recently acquired the Sansum clinics in the Santa Barbara area. So
Awesome.
from north of Sacramento to about Santa Barbara, you got Sutter entities and coverage. Somewhere 25, 27 hospitals, a number of ambulatory surgery centers, continuing growth in the ASC space. We're building a couple cancer centers and a few other joint ventures we have, and really serving the population of Northern California. So, probably 2 to 3 million covered lives from a value-based care plan, as well as just hundreds of thousands of visits, real online presence, as well as a physical presence in a lot of communities in Northern California, trying to deliver the best care. A lot of awards Sutter has. I don't have my slide deck in front of me. If I was doing a PowerPoint, I'd have my
This is
slide of
great.
all the little
No,
awards.
this is awesome. This high level
But
information is awesome. Thank you,
yeah,
Michael.
but good
Yeah.
stuff there. So
That's great. That's good to know. It is a pretty large footprint. So with that, I would like to segue to the first question that, we were kind of talking about a little earlier before we started the podcast about the CMS and the ONC RFI that is out at this time and the TEFCA implementations that you have seen to date. So how do you think about this whole new process that is emerging?
yeah, well, I'll start with TEFCA and then go to the RFI. So I think that the
Hmm.
general idea from the ASCP or ONC or whatever we're calling it these days, I think it's now under CMS, was to really expand on the capabilities of our national networks. So
Hmm.
historically, eHealth Exchange, Commonwealth, and Care Quality were the three national networks serving the population of organizations that wanted to do nationwide data exchange, mostly with CCD documents between organizations on a request response standpoint, securing the connections, delivering that data to organizations that are requesting it. And we've really grown that network to, I think last month in the committee meeting I was in, we exchanged like 1.1 billion documents in the month
Wow.
of April that were exchanged between organizations participating on those networks. And I think that the real crux of those networks is treatment-based exchange, is organizations that are treating patients and need that information to accurately assess the patient, understand the patient's history, and then provide that best care real time. And we really kind of stalled. I mean, we kind of stalled. We were stalled at treatment only. So there were a lot of organizations that couldn't and can't participate in exchange, even though they need access to that information. We talk about COVID and public health. We had a couple of real tangible examples of where having access to information during COVID was paramount, and we made some exceptions to some of those rules following the
Mhm.
emergency orders there from CMS. And so we were able to participate in some of that exchange with COVID, but widely held public health, operational based exchanges, if you're trying to do care gap closures or things like that for your value-based populations, those aren't really supported today on our treatment-based network. And part of that is really bringing in those organizations, that are part of the healthcare ecosystem, but might not have been covered under the EHR incentive program, the long-term care and SNF and nursing homes, organizations that provide care in the community. All those organizations who have a need for patient information were not participants in the current networks that I named earlier. And I
Mhm.
think as we move forward, trying to get that additional percentage, and I think the number was about 30% of organizations that have healthcare data are not participating in the exchange today for treatment. trying to bring them on board and then widen the sphere of organizations that can participate. And that's really the promise of TEFCA, is not only taking the existing infrastructure with the QHINs and some of the other artifacts around TEFCA, but actually expanding those participating organizations and allowing them to not only participate with treatment, which is kind of the first individual access, patient access to their health records, and then the treatment-based exchange is kind of phase one. But the future phases are operational-based exchange, payment-based exchange, public health, research, things of that nature, and really having a network that's purpose-built to support those use cases and those additional entrants to that marketplace that can't participate today because they're not doing treatment-based exchange, or they're not HIPAA-covered entities that can facilitate that exchange, covered by HIPAA. That really drives that. And so as we move forward, CMS has taken on TEFCA. There are 10 QHINs, 8 to 10 QHINs. Most of the EHR vendors have become QHIN, SureScripts, eHealth Exchange, Kanza, a number of others. And really, the RFI is trying to make sure we're moving in the right direction. I think it was looking to seek broad input on the healthcare technology ecosystem, things about provider adoption and usability of digital health tools, strengthening that data exchange, really understanding kind of how you have access to comprehensive patient data, being able to advance value-based care through that technology. So what are the data needs? What are the technology support? How do we reduce that administrative burden? Really being able to give patients access and caregivers access to data that allow them to use digital tools, whether that's patient-facing or to handle identity. How do we ensure that there's equity in that digital health access? And really just making sure we have the right standards in place. What is the certification criteria for folks to participate in that exchange? How do we future-proof those standards? How do we make sure that, again, we reduce those burdens? And I think, making sure that organizations comment and provide feedback to CMS on their experience and how to make sure those things are implemented correctly is vital. So I would encourage everybody to do that. But that's what that RFI is trying to do. And I would encourage that participation as much as you can.
That's awesome. That's awesome to know. Now, moving forward, Michael, to digital health tools and AI, and of course now Gen AI and all the new LLMs which are coming into play. Uh, could you talk with us about what are some of the risk profiles, which and the risk appetite for health systems, and what are some of the examples that you might have seen at your current organization,
Yeah.
Sutter, and at Davis as well?
Yeah, for sure. The AI is used for a large number of
Yeah.
things. NLP, machine learning, RPA, things like that have been in place for a while, and we've been leveraging them for a while to do some of these things. Now we've kind of wrapped these all under the umbrella of AI, but the hubbub right now is Gen AI, is the ambient voice, being able to have a physician in their office talking with the patient. The ambient agent is listening in the background,
Yeah.
consuming that language, and being able to actually generate essentially a note at the end of the encounter, so that instead of the doc staring at the computer and typing the whole time, they can have a conversation with the patient. It's much more personable. And then that agent and that AI in the background allows the physician to have that conversation, but also have a well-formatted note with the important information about that. If you talk about your vacation, things like that are part of the voice recording and transcript, but not actually part of the note. And the AI has done a really good job in that area of being able to provide not only a more close experience, personal experience for the provider and the patient, but also for the ability to get them off of the keyboard and practice medicine. And I think I had, a lot of you don't have to be have supreme typing skills to be a physician, but sometimes you feel like that you're clicking and you're, so when we talk about administrative burden, that AI agent has been really well adopted. The satisfaction scores are high that we've seen. The pajama time, so charting after hours, has really been reduced for those physicians that are using it. And we're trying to expedite adoption across the board. We've seen the same thing with in the Epic. We're an Epic shop, and in the Epic world, there's an inbox agent that looks for the ability to essentially draft and propose responses to patient inbox messages. So a doc could have a panel of 1,000 patients, and you can imagine the amount of email that they get in, or messages they get into that inbox. And the AI agent is actually looking at those messages and really teeing up, not only prioritizing the traffic. So what looks really urgent? how do we make sure we see that first, but also helping tee up and draft some responses that in some of the scoring that I've seen, satisfaction scoring I've seen, is that the AI responses actually are more empathetic than the doc. The doc is taking, typing out a quick response and sending it, whereas the AI agent is actually creating a well-formatted email with, how are you, Mrs. Jones?
Sure.
I see you're concerned about your diabetes, A1C score. I want to make sure you have your lab scheduled, kind of framing that up. And then again, both of these technologies are assistive. And that's actually one of the big things about the concerns about AI risk tolerance, is that they still require the physician or clinician to review, approve before those things are sent or before any decisions are made. I've seen the same thing with imaging AI. In radiology, there's a couple of implementations I've been part of where they're looking at breast images and actually prioritizing. So the AI agent is trained on millions and millions of images, normal and abnormal. And then what it does is it stages the imaging so that anything that looks abnormal gets staged to the top of the radiologist's work list, as opposed to being a first in, first out sort of thing. So you can prioritize that traffic and that radiologist to actually review abnormal images first so that communication gets out. And you think about it, there's a shortage of clinicians in all spaces, radiologists being one of them. A lot of difficulty finding radiologists to do those reads. So leveraging the AI agent to do those reads, prioritize that traffic, and really get patients that have abnormal readings in for care. Same thing with diabetes. There was a tool that we were using for diabetic retinopathy screenings. And it was essentially an image that, if you go to the eye doctor, you stick your head in, they take a picture of your eye, they blow air at you. Same sort of thing, but it takes an image of the eye and then it actually scores for diabetic retinopathy. And it allows for an untrained person to actually set up the device, get the images, so you can expand the implementation, get more images taken, so any of your diabetics can get that imaging. And there was a wait list for the old pre-AI tool, and now you can have thousands of tests and you can expand that out so that you're making sure you're getting the right care to the right patients. And anybody that has a bad image or essentially a reading that says that they've got a problem, you can again prioritize them in the work list. So it's assistive in getting the right people the right care in a priority fashion, as opposed to kind of, again, the old school is, well, when did you get an appointment? Then you get your image, then you get your read, and it's really a first in, first out sort of priority, as opposed to delivering that care correctly. So
that's great to know. So do you think, Michael, that at any point in time, any of this AI, in the examples that you might be kind of working on or seeing now coming your way, that it is going to be autonomous?
I think that there are probably some places where autonomous activity can occur in low risk, and that's where you kind of move to back office, right? So
Right.
a lot of the patient-facing care applications
Yes.
are probably going to be things that are going to be assistive or augmentive, as opposed to actually delivering the final thing. But things in the administrative, like today, a lot of claims and claim status work is I'm logging onto a portal, or I'm sending a message, or I'm doing, I'm sending a fax. I think a lot of those things can be automated. The responses can be automated. You can OCR faxes and do a lot of things. We call it AI, but it's really more RPA or ML, where you're using the robotic process automation to apply some rules to transactions and execute some commands on specific patterns of information, and allows that to happen in a repeatable, a very repeatable and machine-like way. But when you get into things that are, the patient is going to have a procedure, or they're going to have a test, or there's a result, I think those sorts of things, again, I think the AI will allow for a look at a larger data set. You have a patient with a specific condition. You can start leveraging the LLM to kind of go, I have Rohit, and he has this particular condition. And what's the population of patients out in the community that have a similar condition? How were they treated? What were their outcomes? What medications did they have? And start really helping the physician frame a care plan, or plan care.
Yes. Care plan.
You know what I'm saying? Care plan that has, based on 100,000 patients, that has shown to have the right, outcomes on the back end, as opposed to their own anecdotal information or what they might have learned that might be behind the time. So you're going to start to see more research integrated LLM, research data that will allow physicians to target patients with similar profiles to care that historically they might not have been able to access or even understood. because
Yes.
of the training, but it'll still be assistive and suggestive as opposed
Yeah.
to making that actual decision.
That's a good way to think of it. I think the key thing here is the risk factor. So, like I think, like you said, if anything is going to be low risk, it you might be more inclined to kind of lowest risk things you might be more inclined to automate, and
Right.
high risk you might be more inclined to kind of like assist.
Yeah, I'll give you actually an easy example here.
Yeah.
I'm in IT, so I'm participating in a pilot with a blood
Oh,
pressure device, right?
yes.
So what happens is I take my blood pressure. The blood pressure goes to the to Epic, and
Yeah.
part of the AI in the background is looking at the readings. And if my reading is not what it should be, it
Yeah.
sends me a text and says, "Hey, your reading was out of band. You
Yeah.
might want to, take a sip of water and relax for a second and retake your blood pressure in 15 minutes." All
Okay.
that thing is low risk and automated. Nobody has to review the score. It knows it's out of band. It knows that there might be some environmental factors that are impacting my blood pressure. And so
Right.
it automatically sends me a suggestion to say, "Hey, your blood pressure was high. Could you take a reading in 15 minutes after you've had a chance to, calm down, or just,
Yeah.
ensure that the reading, there wasn't something wrong," right? So that
Yeah.
sort of automation it's low risk, it's reviewing the data, so there's some oversight. It actually gives the patient some comfort to say, "Oh wow, somebody's paying attention that my reading was high, and they're actually doing outreach to me." So it's a patient satisfier. It's a safety. I mean, there's lots of pieces there, but it's low risk.
Yeah.
You can take a blood pressure. I mean, I've done it in the office. I've taken a blood pressure and it was a little bit high, and they go, "Okay, well, we're going to take this again." Like
Yeah.
2 minutes later or less than that, the blood pressure is normal, right? So things like that, where you
Yeah.
can actually allow for the care of a larger set of patients. So we're going to distribute that blood pressure cuff to thousands of patients. We don't need to have a ton of nurses sitting in and looking at every result that comes in.
Right.
We really just need to have the rules set in place to say, if something's out of band, send them for another one. And if it's out of band again, then alert a physician or a clinician who might then reach out to the patient and say, "Hey, you've had a couple blood pressures in a row. We might need to adjust your medication. We might need to have you
Yeah.
come in for a visit." Or,
Yes.
"This is really bad. Go to the ER," right? And I think
Sure.
that's
Sure.
where you can apply the right resources in the right way when you look at AI as a tool to help prioritize your risk for patients that have higher risk, and you have information that you can act on more immediately. You can have a person acting on that as opposed to technology. And I think those are the sorts of things, as we get more advanced with that, will expand into different use cases besides blood pressure, to really provide that personalized medicine. I think back in Bush, we talked about personalized medicine, and they tied it to your genetics and your genome and DNA. I think personalized medicine is really treating each patient as an individual, and then
Yeah.
providing them feedback around their health conditions and the support to actually manage those proactively, as opposed to when there's an adverse health event. And I think that's where we talk about value-based care is, we want to push people out of the hospital. We want to care for them before they become sick. And I think a lot
Right.
of these tools, and again, that's a low risk thing, right? They haven't gotten sick yet, but they have a condition that they need to manage. A lot of these tools in value-based care are going to make a lot of sense. We just need to figure out a reimbursement model and incentive model that encourages not only the patients but the providers to use those, so that there's some incentive to adopt these technologies, as opposed to waiting for them to get sick and then go to the hospital, which again is
Of
expensive for
course.
everybody. So
Of course. Of course. So Michael, moving on to another, aspect of like innovation, right?
yeah,
And thinking about innovation in the framework of new announcements, like Oracle has announced, a completely new redesigned EMR EHR system, and we all know that Epic is, the big, you know, heavily used system, by the health plans and health systems. So how do you think about innovation in this scenario? And what are some of,
yeah.
yeah, thoughts around
Yeah, I
it?
mean, I think that one of the things about, and again, Epic is a significant vendor in the electronic health record space. They're a market leader. They deliver a great technology. Again, I've been a customer of Epic since 1998, so I'm very familiar with them and their architecture. I think that one of the things about modernizing electronic health records is really abstracting the data and the workflow and the technology. So Epic, just like most of the historical EHRs, was built first as a billing system and then as a clinical documentation system. And a lot of the workflows and things that occur inside of current day EHRs, including Epic, are really tied to how do we make sure we document the appropriate things so that when we send the claim to the payer that they're going to pay it and not deny it because we've checked all the right boxes or we've coded it correctly. I think that if you look at, and again, just Oracle's their ambitions of kind of taking that over is leveraging AI native, cloud native, a new user experience that really focuses on the clinical workflow and what makes the most sense there, and then figuring it, reverse engineering it so that instead of thinking about the billing process first, you think about the clinician experience first, and then figure out how to use AI and different tools to actually administer and handle those administrative functions at a different level. And I think that's where you look at whether it's Epic or Meditech or Cerner or Oracle Cerner or Altera. I mean, again, Greenway, Athena. I don't want to leave anybody out here, but when you look at kind of the future forward, is those are great platforms. They have a great data structure and information. But when we look at what we need to build is we need to make sure that the right workflow is enabled for the right specialty and the right clinician and has some personalization that allows them to work in a way that they'd like to, that makes sense to them. But all while still having access to all that data. So if we separate and create some data liquidity, and I think that's what they're trying to do with the Fire APIs and API enabling everything on the back end, is now I'm not chained to a Epic, Cerner, Oracle, Meditech. I'm not chained to their UI. If I can access the underlying data structures, then I could build an app on top of those data structures that allows those workflows to be more fluid and user-based. Again, I think we've gone through different iterations of UI development where you have your widgets or whatever you want to call them, even the apps on your phone or your apps on your watch. I think that when we look at the future of this, is whether this is Oracle's vision or how they're going to do it, but really trying to make sure that we're building a UI and workflows that are intuitive to clinicians that meet their needs as opposed to meet the needs of billing, and then re-engineering it so that the billing processes and the checking the boxes for claims and all those other things are where that AI and that automation take place, so that you're not robbing the innovation on the front end to serve the back, to serve the back end, is you're really innovating on the front end and then leveraging all that technology and AI to serve the back end, and maybe prompting clinicians for things that they need to have, as opposed to requiring them to check a boxes. Did you ask them about smoking status? Did you check on this? Did you not check on that? So, I think that's where we're going to go, whether it's Oracle or whether it's really just a smart, innovative technology person that comes in and says, we're going to leverage the Epic data structure because the replacement cost today for an EHR is exorbitant. I mean, rip and replace Epic to put in some new technology that you're not sure is going to work is a high risk thing. But if I could implement this new UI with Smart on Fire application that does this really cool thing for cardiology, that's much better than what Epic does or any other system, then maybe I can get some headway into the market, and then I can build other use cases and applications for other specialties. So we're not going best of breed whole hog. We're just going best of breed of UI and leveraging the current EHR that you have in place, their infrastructure and their data structures to actually feed that new process.
That's a great perspective, Michael, on innovation, and I really like the term that you used, which is data liquidity. So I think that is awesome way to think about it. So as we come towards the end of our podcast, Michael, I wanted to touch upon one more item with you before we finish, is about the California data exchange framework, which is relatively new, as you mentioned before when we were talking. So tell us a little bit more about that, and where do you see it going in the future?
Yeah, so California, like every state, thinks they're unique. So Governor Newsom signed the data exchange framework legislation a couple of years ago, and really what it's doing is trying to establish, I'll call it parallel, but essentially a data exchange inside of California that allows for a patient or a person who lives in California to have access to their longitudinal health record, to include social services data, public health data. And they've created a similar TEFCA-like QHIO, so Qualified Health Information Organization, as the TEFCA-based QHINs, and those QHIOs are helping facilitate these organizations to participate. So there's a requirement to do admit notifications. It's a requirement to do panel management. It's a requirement to do direct messaging and essentially data exchange for treatment, operations, those sorts of things, public health. And so today the data exchange framework is a legal framework, but there's not a technology framework. They're really trying to be technology agnostic and allow each organization to come and participate with the technology they have available. Part of the challenge is that that requires essentially a bunch of point-to-point individual connections. So if I want to exchange data with some housing agency in Sacramento or a public health organization in Sacramento, I need to work with them and figure out how to do that. But the data exchange framework provides me legal cover and a data use agreement that says, yeah, the state has authorized this. There's not any, it's okay to do this exchange. You don't need any other agreements. And I think that one of the pieces is that you have these different groups that haven't historically participated in exchange, again, treatment-based exchange, like I talked about before with the existing networks. And so it's what data can public health have? What data can a housing agency have? What can a non-covered entity have access to? And how do we connect with them? What's the security profile? How do we ensure that the right people are participating? Today, if you wanted to know who signed the data exchange framework that was part of that network, you'd have to go to a website and look them up on an Excel spreadsheet. So, one of the things future is really having the technology infrastructure to support that exchange, as opposed to as a point-to-point basis, as a kind of a network effect. So a parallel TEFCA. So, it's something that we're really excited about. I'm working with Blue Path Health team, EMI advisors. They're all part of the team leading this out here in California, making sure we're moving in the right direction. I'm on the technical advisory committee that's run by CDII, trying to provide that feedback and input so we get some technical standards in place and some frameworks in place that allow that exchange to happen. But it's an exciting move, and again, it's SB 660 was just recently making it through committee, and it's going to put some more teeth into actually participating in exchange, not just policy around signing the agreement and saying that you'll participate. It's actually going to put some teeth behind it. So it's going to be an interesting few years here in California. And AB 352 preventing abortion services data from leaving the state created some challenges. So those things are all tied up. California's got a lot of data and interoperability, governance or regulations in place that we're all trying to comply with. And hopefully we can leverage the data exchange framework to essentially help us with that compliance.
That's awesome, Michael. So any other parting thoughts for the listeners of the podcast from your side? I think we are going to wrap up. So
I think that there's a lot of things going on. I think if you look at it its entirety, it can feel overwhelming. And what I would tell you is that just like I tell my kids when they go to college, get involved, participate, even in something small. Find people that you know or that you don't know that are involved and learn. I mean, a lot of the things that I've learned through time have been in engaging in conversations with really knowledgeable people. I participate with on the podcast, the Health Tech Talk Show with Lisa Bari and Kat McDavitt. They're so well informed. Lisa was the former CEO at Civitas and now works for Innovacer. But Brendan Keeler's done a lot of writing on LinkedIn and has a blog that talks about a lot of these things. Get engaged, join a committee, really make sure that your organization is really set up for success. Because if you're in the interoperability space or the health tech space and you don't understand how this is going to work, and you aren't moving your organization forward, you're going to get left behind. And I would just encourage people to engage, understand, provide feedback to the RFI. If you haven't read it, get online. Maybe you can plug it into your AI and it can summarize it for you, and leverage those tools, but really engage and participate. I'm always a resource. As I tell people, I'm an open book. So if you have questions or concerns, feel free to reach out to me, connect with me on LinkedIn, and we can have a fun conversation. But I appreciate you having me here on the podcast, Rohit. Exciting times ahead for all of us, for sure.
Yeah. Thank you, Michael. This was a great conversation. And I will
enjoyed it.
Likewise. Thank you so much.
Thank you.
Thank you.
Have a good day.